Okay. So we're going to talk a little bit, and we've already kind of talked about all this again, but just to kind of drive it home and make sure that you take what you need to from the IV therapy portion of this course. So when we're talking about asepsis, when we are starting IVs, when we are messing with our lines, our primaries, our secondaries, all of that stuff, it's incredibly important to know that the portal of entry, y'all know when we learned about the chain of infection, you have to have a portal of entry. The portal of entry is going directly into your patient's bloodstream. It's going directly into their vessels. So if you contaminate your catheter tip when you're inserting it, those pathogens don't have to travel from their nose down their throat to their lungs, and all of that whole little process. It's directly, there are, germs directly in their bloodstream. So those then become bloodborne pathogens. Sometimes our body can take care of them, our little macrophages, they can eat all of that stuff. Sometimes they can take care of them. And sometimes that bloodborne pathogen becomes a full-blown sepsis. They have infection in their blood, and it is life-threatening, and it is a problem. So our biggest role, I guess all the roles are big, but one of our biggest roles in IV therapy, in maintaining a PICC line, in hanging piggybacks, and starting IVs, anything that has to do with IV therapy, is keeping our lines from becoming contaminated. And we want to decrease the patient's exposure to unnecessary incidents that can cause hospital-related infections. I know y'all have heard of MRSA. So very often people have MRSA of the blood, and very often it comes from the hospital. And you know why? We carry it in our nose. And so y'all have seen how much my nose is run today, right? And I keep itching my nose and touching my nose, and I'm not gross. I'm not digging in my nose right now, but I'm constantly touching my face. And if I go in and I then touch my patient without cleansing my hands whenever I walk in the door, it's not always like you're licking your finger in. The ways that you spread infection are not always just visible, disgusting ways. They're going about your everyday normal life and failing to take those measures that we're supposed to take, like cleansing our hands before as soon as we walk into our patient's room, and applying our gloves before we insert our IV, and all of those things. Just making sure that we do our part in preventing nosocomial infections, which y'all know are hospital-acquired infections, and that we decrease our risk of occupational exposure, which is us being exposed to blood on the job and not wearing our PPE as we're supposed to. So anytime you are starting your IVs, especially while you're in school, your policies will vary when you are in the workforce, but you should always protect yourself. When you're starting IVs, you should wear your goggles in case there is a blood splatter. You're working directly with blood, and you're probably going to make a mess. Wear your gloves, do what you need to do to protect yourself, okay? So proper disinfection and hand hygiene are key in medical asepsis. This is foundation stuff that but it's so important in regards to IV therapy, okay? The LPN must practice both aseptic and surgical technique when initiating IV therapy. So I had a couple people ask me, the IV therapy kits that are at the ones we were practicing with, they actually have sterile gloves in them. And they were like, do we have to use sterile gloves? No, technically it's not a sterile procedure. Your IV is sterile, and your catheter is sterile, and then you're cleansing that site. But if you're provided with sterile gloves, it doesn't hurt to put them on. It doesn't hurt to go that extra step that takes 2 extra seconds to protect your patient further. So technically not a sterile technique, but it definitely can and should be taken with the utmost, as good as you can do it, because we know that you are going to have to touch other things. Now, in regards to spiking your IVs, that is a sterile technique. You don't have to have sterile gloves on to keep one sterile end to another sterile end. Y'all understand how that is still sterile even though you're not applying sterile gloves. That is always going to be, you never want to contaminate that spike. The same way with your, yesterday, I was kind of getting a little flustered when we were doing our IV. When your hub of your needle, don't be afraid to touch the pink part, but that entry portion, the part where you're screwing in, just for, we're going to call them the male and female pieces, when you're lure locking those in, your hands don't ever need to be touching any of those connectors. It's not necessary, and you're introducing pathogens when you do that. So always make sure that when you're spiking stuff, when you're screwing stuff in, when you're done with stuff, that you're capping it, that you're not laying it on the bed or the floor. Same way with when you're attaching your extension tubing, place it back into that sterile package. Don't lay it on the bed or the bedside table. All of those are ways that you can introduce pathogens to your patient. Y'all know that, I mean, like I said, all this is foundation stuff, but always consider the length of your nails. Acrylic nails, nail polish, rings, all of that stuff needs to be taken into consideration throughout your entire healthcare career, not just with IV therapy. So disinfectants or chemical preparations that are used to kill or eliminate pathogens from objects. They're not used on the skin or the mucous membranes. So like these are our things like, you know, the little purple top, I can't think of what they're called right now. You know, the purple cabbie wipes, the little cabbie wipes that we're wiping stuff with. Make sure that your patients aren't using those on their skin. Make sure you're not using those on your skin. Those are your disinfectants for objects. Antiseptics are going to inhibit the growth and the reproduction of microorganisms, and they can be applied to the skin and mucous membrane. So just make sure that you're using whatever cleanser your facility approves. So when starting your IV, chlorhexidine is a better choice than alcohol, and usually those chlorhexidine wipes are going to be coming in your packaging. If it says, we always want to let it dry thoroughly, because it's not doing its full job if we're not letting it dry. So don't, as soon as you wipe, on top of burning your patient, don't as soon as you wipe your IV, put it in immediately while it's wet. We want to make sure that we're given that antiseptic time to dry on the skin. We know that the skin harbors numerous pathogens. Staphylococcus is very, very often found on the skin, and therefore that's why it is MRSA, you know, is methicillin-resistant staphylococcus. So very often that is how staphylococcus enters the body, is through that lumen on the outside of the catheter, because it's touching everything, and then again it's going directly. So your patient doesn't necessarily have to have boils on their skin to have staph on their skin, but when it is introduced in such a way into the actual, I guess, bloodstream, y'all know what I'm saying, into central circulation, into their circulation, these bloodborne pathogens could be life-threatening for them. So always keeping that in mind. And y'all know the chain of infection. I kind of put this on your little study guide. You have to have a causative microorganism. You have to have a host source. You have to have a portal of exit, a means of transmission, a means of entrance, and a susceptible host. So just taking this at the end, you can see our portal of entry is our IV insertion site. It's already there, open and ready. So that causative organism could be laying on the sheet next to your patient. It could be on the bedside table. It could be on your hands. It could be anything. You could cough, sneeze. All of those things are, it's just a break in the chain of infection if you, if you break any of those areas where you should be using asepsis. And the thing is, hospital-acquired hospital-acquired infections are very real because almost everybody in the hospital is a susceptible host. They're already immunocompromised, or they are already have a catheter, or they have something that's making them a susceptible host. So just keeping that in mind as well. I feel like y'all know all this stuff already. PPE, don't let the linens touch the floor, because when the linens touch the floor and then their IV touches their, it all just cleanse your ports as you're supposed to. Encourage good nutrition. And then surgical asepsis versus medical asepsis. All of it, I mean, y'all know this stuff already from foundations, don't you? Or do you need me to go over it? Medical asepsis, we're going to use that during non-invasive procedures. Those are your typical things that we're going to do, like cleansing our hands when we come into the room, making sure that we're not bringing equipment from one patient's room to the other. Even if it's just an IV pump, we need to clean it with the cavi wipes before we go in there. Now, surgical asepsis is we're maintaining sterility. We have sterile supplies. We have sterile equipment. We're scrubbing that site. We're using sterile gloves, all of those things. IV therapy. The inside of the fluid bag is sterile. Y'all know that. That's why we can't touch when we're spiking it, that's why we can't touch that. The Gelco is sterile, the actual IV. Remember I told y'all they have different names, but the IV catheter itself, once you remove that cap, it is sterile. So you should not be touching all over. If you want to loosen it, I think I told some of y'all that. When you go to insert your IV, sometimes it's hard to slide it forward. You can loosen it if you want to beforehand, but you're not going to touch the actual needle. You're not going to touch that catheter in any way, okay? And again, the spike on the tubing is sterile. The other thing that is sterile is your extension tubing that you're screwing into your insertion site. We want to make sure that we're not touching those things either. You can touch on one end and the other end without ever introducing your hands and touching the inside of that stuff, okay? This is blowing up my email today. And of course, hand washing prior to everything. And then y'all know universal precautions. Sharps must be placed in the sharps container all the time. And you always want to make sure that you know where your blood cleaning kit is when administering blood, when starting an IV. Make sure that you have red bags in the room. Make sure that you're disposing of things the way that you should. And then universal precautions with IV therapy. You always want to palpate the catheter insertion site for tenderness daily through the intact dressing. So the biggest thing about that, we always want that insertion site to be covered with that transparent dressing so that we are never directly touching that site. We're always able to visualize it and feel it from the outside of that tegaderm without causing any entrance. We're not having a portal of entry there because it's remaining covered. So in the same way, when that dressing is soiled or peeling or wet or gross, is it doing what it's supposed to do in order to block that portal of entry? It's not, so then we would change it. And we talked about replacing the tubing in our last before the other test every 72 hours, unless it's blood, lipids, or TPN. That is only good for 24 hours. You must, I don't think I've jumped up and down on this enough. You must date and time your IVs. You must date and time your tubing. All of that is going to decrease that opportunity for infection as well. If we know when they went up, then we know when they come down. So make sure you're doing that. Make sure you're scrubbing your hub. We've already talked about all of this stuff. We do not routinely apply antimicrobial ointment to the insertion site. So some people are all about like Neosporin and all of that stuff. We're not going to put Neosporin and any kind of antimicrobial stuff on the outside of that insertion site. We're going to keep it clean and dry, but we're not going to apply any extra ointments or anything to those sites. And needle safety. So if there is a needle stick on the job, you must tell your supervisor immediately. There needs to be an incident report will be done. There'll be a description of the incident, identification of the individual whose body substance may have been on the needle or sharp. One time, I was stuck one time with a needle when I was actually sliding the safety clamp. I think I told y'all that. You know how you engage your safety stuff and you slide it forward? It was real flimsy. And whenever I was engaging the safety, I was going real fast and I poked myself as I was engaging the safety needle. So be sure to go slow. You know what I'm saying? Like, I wasn't necessarily doing anything wrong. I was just sliding my little safety clamp forward so I wouldn't poke myself, and I poked myself in doing that. So just make sure that you are taking your time, that you're not in too much of a rush, because when you stick yourself with a dirty needle, you have to go to employee health. You have to have all kinds of blood drawn. They have to draw blood on the patient who had the needle who the needle patient that you use the needle on, they have to draw a panel on them. They have to draw a panel on you. There's testing 3 months later to make sure that you have not been exposed to anything like Hep B, Hep C, HIV, all of those things. So reporting any kind of needle sticks is incredibly necessary for your safety. That's really it. I feel like y'all know all that stuff already, but I can't just go without saying it either. Any questions about asepsis?
I have a question.